Hello viewers, today I will discuss my next case discussion topic, that is on endodontic file bypass tips and tricks. Now first I will discuss all the tips and tricks for the bypass of fracture fragment within the root canal system. Next I will show some of my cases where I did the same technique to bypass my fracture fragment of the instrument within the root canals. Now the rule number 1 is, just after the fracture of a file within the canal, immediately do a X-ray. Now, why the X-ray is important? In order to locate the size, in order to locate the probable position of the fracture fragment, whether it is above the curvature or below the curvature, in order to have an idea regarding the size of the fracture fragment, in order to also having an idea about the length of the fracture fragment. So just after the separation, you have to take an X-ray first, followed by gathering those information of the length, sizes, and the position of the instrument. Next, place a smaller file, that is a 10K file, here on the left side radiograph, and find a catch between the fracture fragment and the wall of the dentine. That is the passage where you will be doing your bypass technique. Now just you find a catch between the fracture fragment and the wall of the dentine, progress by 0.5 to 1 millimeter, then again do a radiograph. Now why this radiograph is helpful? It is because whether the tip of the file you chose to bypass the fracture fragment is placed in the inner curvature, that is on the left side radiograph here, or on that is placed on the outer curvature as you see in the right side of the radiograph, is important. So just after initial binding within the fracture fragment and the wall of the dentine, you took an X-ray, and this is important to know that your file is going towards the outer curvature. Here it is not desirable, or in the inner curvature, which is ideally should be maintained during your bypassing technique. Now rule number 2, when you found that your tip of the instrument which you use for the bypass is present on the inner curvature, now progress through the fracture fragment and the wall of the dentine in a watch winding motion, not in a reaming motion. Okay, now watch winding motion is continuous clockwise and anti-clockwise rotation, so it will give you the stress for the screwing in of the file, as well as it will help to release the stress when you do a anti-clockwise rotation. The continuous reaming motion to reach to the apex is very risky, as because it will cause another fracture of your files, which will further complicate the situation. Now after every zero point 0.5 to 1 millimeter of progression between the fracture fragment and the wall of the dentine, you should check the file for any kind of visible unwinding. Remember the thing that when you doing your bypass, you may require one file, you may require two files, three files, four files, or more than six files. That depends upon the passage, that depend upon which size of instrument is separated, and the available passage between the fracture fragment and the inner wall of the dentine. So if it is large, you will require less instrument for the bypass. If the passage is small, you will require more instrument to bypass. So every 0.5 to 1 millimeter of progression, you should check, that is present on the left side of the picture, for any kind of visible unwinding here. If there is any kind of visible unwinding is there, so you have to change the instrument in order to further fracture this instrument, which will complicate your situation. Now rule number 3 is, when you completely able to manage the bypass and reaches the apex through your small file, that is a 10K file, immediately check the working length with the help of apex locator, followed by took an X-ray to confirm the working length. Now just after you took an X-ray confirming that it is the working length and that is the apical most part where you reached already, now do a filing motion without removing the file. Now why I am telling the doing a filing motion? Now filing motion is continuously push and pull motion. Now push and pull motion will give you a reproducible glide path that will help that 15K or 20K, that is further files, to reach the area. Now remember that after the filing motion with your small k file, that is a 10K file, when you insert a 15K file, at least enlarge up to 20 or 25 size K file, followed by you should go again with the rotary to complete your chemico-mechanical preparation. And it is also it is also noted that it should be used always with hypo and EDTA. That is, hypo will be placed on the chamber and EDTA should be coated on the files, as because the carbamide peroxide present in the EDTA will react with the hypo to form the bubbles which will emulsify the debris that is present during your bypass. So it will prevent any kind of blockage during your bypass with the help of 10, 15 or 20K files. After enlargement of the canal up to at least 20, now you can ready with your rotary to complete the chemico-mechanical preparation and then the obturation, as you see in the right side radiograph here. So this is the basic rules or basic tips and tricks which I followed in all of my cases. Now the first case is, this is the tooth number 37. In the preoperative X-ray you will see the caries involving the pulp horn of this 37, also in 36 also. So this is the working length of this 37. Now everything was all right. On the right side radiograph you will see that there is a separation of a shaping file, that is S1, in the middle third of the mesial root of this 37. And with the help of this file, that is a 15K file, first I use a 10K file, followed by I use a 15K file and confirm the working length after the bypass using the same techniques that I described you earlier. This is the master cone. Now if you see the master cone, here is the fracture fragment in the middle third, and the fracture fragment length is approximately 3 to 4 millimeter. Now this is the picture of the obturation. On the left side this is the mesial angulation, and on the right side this is the distal angulation. Now this is the fracture fragment on the distal angulation here, and this is the fracture fragment here. As it is a mesial angulation, it is a mesiolingual, so here is the fracture fragment. Now this is the follow-up X-ray of approximately 2 years of follow-up. Patient had no complaint of pain or any kind of periapical abnormality in radiograph is not also present even after 2 years of the treatment. Now this is the second case of mine. Here in the 6th, there is a lower first molar. Caries present in the occlusal surface of the tooth involving the pulp chamber, and the patient complains of typical symptomatic irreversible pulpitis features. Now this is the working length X-ray, 2-1 canal configuration on both the mesial and in the distal side. Now note here, there is a 5 millimeter protaper next X2 fracture, protaper next X1 fracture in the apical third of the mesiolingual canal here. The approximately length of the instrument is 5 millimeter. Location in the apical third canal is mesiolingual. Now after that, I using the same technique as I described earlier, I Started the bypass using a 10K, followed by enlarge it till 20K, and then again the BMP I've done. And this is the master cone X-ray on the left side. It is a mesial view, and from the straight view, if you see this X-ray on the right side, this is the coronal end of the fracture fragment, and this is the apical end of the fracture fragment. And from this to this, here to here, this is the GP that crosses the file and reaches the working length. Now this is the obturation. This is the mesial side X-ray, that is a mesial angulation. This is a distal angulation. Here you will see that the mesiolingual GP comes adjacent to the fracture fragment. It will go, yes, this is a mesiolingual GP. It passes just adjacent to the fracture fragment and reaches the apex here. See, this is a GP, this part. Now if you see this part, this is the apical end of the fracture fragment. From this to this, it's a complete bypass. Now on the right side picture, it is a distal angulation. So this is the mesiobuccal and this is the mesiolingual. Here you can see also that mesiolingual GP able to bypass the fracture fragment. Here, this is the fracture fragment, this, and this is the GP. It comes like this here, and then like this. Now this is the follow-up X-ray of that tooth number 36 of approximately 1 year 8 months, and no such issue to the patient till after 1 year 8 months, and no such periapical abnormality, and the tooth is normal in form and function. Now this is the third case of mine. Here already a fracture fragment is present when the patient came to me in the distobuccal canal of the 1/6. Now this is the X-ray of the working length. Here with the help of a 10K file, you see I am able to manage to bypass the fracture fragment here and reaches to the apex till this point. And this is the master cone X-ray. If you will see that it reaches to the apex adjacent to the fracture fragment on the distobuccal side. Although I tried my best, but I didn't find any kind of MB2 canal in this 6. Only I am single canal, that is mesiobuccal. Now this is the picture of the obturation. This is the mesiobuccal, this is the palatal, this is the lateral opening of the palatal, and this is the distobuccal GP adjacent to the fracture fragment. This is the fracture fragment. This increased radiopacity part, this is the fracture fragment, and this is the GP reaches to the apex. Now this is the follow-up of 3 years of this case of this tooth number 1/6. Although I didn't find the MB2, but no such periapical lesion or any kind of symptoms to the patient till at the end of the 3 years. The patient is absolutely fine. So this is all about the discussion of this case discussion. So if you like, if you this video, and if you found helpful this video, so don't forget to like, comment and subscribe my channel. We will meet in the next video very soon. Thank you very much.